Well, thank you very much. I'm going to change direction a little bit from Cliff's talk. This isn't going to be about complex cellular biochemistry and physiology, but really about something that we run into in the ICU every day, which I had thought would be fairly straightforward, but as we've studied it, has proven to be somewhat different from what I anticipated. So I'm going to be reporting to you the results of a pilot clinical trial that we did several years ago. So here's the challenge, and I want to get some input from those of you in the audience about this. You're looking after a man in the ICU. He's 64 years old. He has comorbidities, chronic lung disease, heart disease. He had a gastrectomy 5 days previously. He remains in the ICU. He's intubated. He's on a low fraction of inspired oxygen. He's got lines in place. He's got a Foley catheter. He's hemodynamically stable, not particularly sick, just slow to wean from the ventilator. Chest X-ray is quite nonspecific. There's some atelectasis, a small effusion on the left side. And his temperature, as you're doing rounds this morning, is 38.2 degrees. His white count is 14.2. So the question here is, this man has stable physiology, low-grade temperature, low-grade white cell count. He's not currently on antibiotics. How many people here would start empiric antibiotics? Can I see with a show of hands? Okay, a few. I'm seeing maybe half a dozen, maybe a few more, maybe up to about 10, maybe. And as people become a little bit bolder, maybe 12, maybe 15. Okay. How many people would not start antibiotics under these circumstances? Okay, I'm seeing there's more hands going up, probably more in the range of 20 to 25. That certainly would speak with my convictions on this issue. And I wanted to show you what, this was the question we asked. We run into this problem in the intensive care unit frequently, a patient who may, on the basis of some very non-specific clinical findings, have an infection. And the question comes, we obviously want to diagnose an infection, but should we be treating it empirically, or can we wait? So antibiotics really are one of the great discoveries of the 20th century, but they are definitely a double-edged sword. They have both a good side and a bad side, very much like this picture, which if you look at it one way, you see two nuns standing in an archway of an old temple. If you look at it another way, you see that they become the head of Voltaire, and he has this kind of benign smile on his face. Same picture, but two very, very different interpretations. And I think our understanding of the process of infection in the ICU has many elements of this kind of dichotomy in it. Because when we give an antibiotic, obviously, if there is a dominant microorganism that's producing disease in a patient, we can reduce the numbers of organisms by killing them with the antibiotic. We can assist in the resolution of infection, and we can make the patient better. And very few would argue with the beneficial role that antibiotics have to play in patients who are infected. At the same time, we know there's a cost to doing that, and that is that by suppressing that organism and suppressing a class of organisms that are sensitive to the antibiotic, we're creating an environment where organisms that are not sensitive can overgrow. And so we are promoting species that are antibiotic resistant to emerge. We're also providing an evolutionary force which will cause those organisms which are sensitive to the ones that have a gene to metabolize the antibiotic will dominate, and so you'll support the emergence of resistant organisms. So for the individual patient, antibiotics may be beneficial, although they carry the risk of things like Clostridium difficile. For the environment, on balance, the more we use antibiotics, the more we're going to promote resistance. And that's a real crisis in antibiotic use right now. And so we undertook a study that we called the AATICC study. This is Marianne Arts, who was a master's student working with me. It was her master's project. It stands for Appropriate Antimicrobial Therapy in Critical Care. And our question was really to look at empiric antibiotic use for nosocomial or suspected nosocomial infection. Again, just to underline the importance of this dichotomy, we know from observational studies that starting antibiotics early is beneficial, But again, these are a select group of patients. These are patients with community-acquired infection, with significant severity of illness. They're all patients with septic shock. And Kumar showed very nicely that the longer you delayed appropriate antibiotics, the worse the outcome was. There have been a number of studies that have suggested that starting the appropriate antibiotic empirically in patients with infection in the ICU improves clinical outcomes. This is one of those studies where they suggested that if you gave adequate antibiotics, the mortality was only 38%, whereas it was 71% if you delayed administering adequate antibiotics. If you gave inadequate antibiotics, the mortality went all the way up to 91%. Interesting, it was slightly lower if you delayed giving inadequate antibiotics. And intriguingly, giving no antibiotics at all was somewhat intermediate between those. Now, there is a potential source of confounding in this because it's difficult to differentiate a clinical decision, the decision to give antibiotic X, from a patient characteristic, and that is infection with an organism that is not susceptible. And so one of the problems of these observational studies is, are we actually showing the benefits of antibiotics, or are we showing a systematic difference in prognosis for patients who have infections with resistant organisms? And I showed this slide in my talk this morning, but I want to go over it again. This was a study of 527 patients in whom clinicians suspected they might have an infection, very much like the patient I showed you, and therefore conducted a number of diagnostic tests, including measuring endotoxin levels. And we asked the question, what were the risk factors for death? What we found was that the characteristic risk factors that we normally think of, age, illness severity, use of vasoactive therapy, were all independently correlated with the ultimate risk of death, but the actual diagnosis of infection was not. So it raised the possibility here that infection, as acquired in the ICU, although it occurs in the sicker patients, it may not be as much of a risk factor for death as we thought. And conversely, when we looked at those patients who ultimately were adjudicated not to be infected, so we went through all of these 527 patients, and we, taking all the information we had after the fact, decided whether the patient was or was not infected. If you were adjudicated not to have had an infection when the antibiotics were started, and if antibiotics were continued for at least 4 days, you almost had a statistically significantly higher risk of dying. So again, it doesn't show a lot of evidence that the sort of widespread use of broad-spectrum antibiotics may be beneficial in the specific setting of nosocomial ICU-acquired infections. So there are other data that would kind of go along with the notion that ICU-acquired infections are different from community-acquired infection. This was a systematic review we did of antibiotic therapy for ventilator-associated pneumonia, 38 clinical trials, almost 7,000 patients, and of these, the majority of them were mechanically ventilated. The details of the interventions, and there were about 28 or 29 different comparisons, are not important here. The important thing is that for no intervention was there evidence of the superiority of treatment of with one antibiotic versus another antibiotic. So in other words, at least in these studies, there was no suggestion that the selection of an antibiotic at the time of diagnosis of ventilator-associated pneumonia made any difference on mortality. Now, none of these are placebo-controlled trials, understandably, but they do, again, call into question somewhat this notion about the adequacy of therapy being a significant risk factor for potential outcome. And indeed, there are at least 3 randomized controlled trials in the literature that suggest that a deliberate strategy of minimizing antibiotic exposure may benefit patients. Nina Singh did a study where, using the CPAS score, they discontinued antibiotic therapy in patients at low risk of pneumonia and showed a significant reduction in subsequent rates of resistance. Jean Fagon from France did a study where antibiotics were tailored on the basis of BAL results, and they actually found a significant mortality reduction. And then Jean Chaste, as you probably know, did a study that limited antibiotics by giving them for 8 days rather than 15 days, and again showed a resistance benefit for less antibiotic exposure. So there is a signal there that strategies that minimize unnecessary antibiotic exposure may actually help the patients, certainly they don't seem to be harmful. Now, one of the key issues here is that nosocomial infections in ICU patients are different from community-acquired infections. They differ in a number of very important respects, including the fact that they're often very difficult to diagnose. That patient I showed you could have a line infection, he could have a urinary tract infection, he could have a ventilator-associated pneumonia, or he could simply have a fever on the basis of some atelectasis or perhaps a deep vein thrombosis. Very, very difficult, very nonspecific signs, and it makes the diagnosis challenging. Typically, these infections arise in association with invasive devices. Ventilator-associated pneumonia requires the presence of an endotracheal tube and probably arises because bacteria cling to the endotracheal tube and can be shed from the tube into the lower airways. Line infections, we heard about this morning, arise because the catheter becomes colonized, and they can be prevented by strategies that minimize the risk of catheter colonization. Urinary tract infections, same thing. The organisms grow in biofilms on a Foley catheter and are shed into the bladder, and that's how one develops a urinary tract infection. Moreover, a lot of the organisms are relatively avirulent. Coagulase negative staphylococci, enterococcus, even Pseudomonas. Back in the 1950s, Pseudomonas was thought to be a harmless environmental pathogen and the organism that was responsible for the smell associated with dirty socks. It was not thought to be particularly virulent as an organism, although it clearly is in our patients. But these organisms tend to be very resistant to antibiotics. And ultimately, the mortality or morbidity associated with these is uncertain. So these considerations then led us to design a pilot study that was a placebo-controlled trial of empiric antibiotics for critically ill patients with suspected nosocomial infections. And we called it the AATICC trial, which stands for Appropriate Antimicrobial Therapy in Critical Care. Now, we realized it was going to be very challenging to do a study like this, particularly given that we were using a placebo arm. And so rather than undertake a large trial to see a clinically important outcome, we decided to undertake a small pilot trial to see if we could actually do that study. So here's the study hypothesis. We hypothesized that for critically ill patients with suspected nosocomial infection, and I'd emphasize that this is suspected infection. You were excluded if you had objective evidence of infection. But for those with suspected infection, we hypothesized that giving a narrow spectrum antibiotic therapy based on the results of cultures would be as efficacious as giving a broad spectrum empiric antibiotic therapy at the time that you suspected the infection. If that strategy was accompanied by full source control, changing the lines, changing the Foley catheter, getting rid of the potential sources of those infections. We further hypothesized that if we could do that, we could reduce rates of superinfection and antibiotic resistance. Our hope here was that by doing this kind of study, we could essentially eliminate the concept of having to give broad spectrum empiric coverage for suspected nosocomial infection. So this is the protocol for the study. And I want to go through it with it just because there are some important considerations here. Patients were identified as being having a suspicion of infection if they had a temperature greater than 38.5 or greater than 38 with a white count of 12,000. So the man I showed you would have been eligible. This had to be nosocomial, so they had to have been in the ICU for at least 72 hours so that anything obvious would have been picked up. And they had to have a suspicion of infection, but we excluded any patients who had findings consistent with infection, who were about to die, had prosthetic heart valves, had any factors that might mean they'd be at increased risk if they developed an infection. And importantly, we excluded any patients who'd received a dose of antibiotics within the past 24 hours. So once we had done that, the patients could then be consented and randomized, and they were randomized either to placebo or to broad-spectrum antibiotics, which were selected by the 8 different study sites. Each site said, this is our empiric antibiotic or antibiotic combination, and that would be what the patients were randomized to. Before that happened, they'd undergo a very intensive diagnostic workup and source control, which meant changing lines and changing the Foley catheter. Once that had been done, once a diagnosis of infection was made, the study drug would then be stopped and the patient would be switched to narrow-spectrum therapy as guided by the results of culture. If there was no infection, the study drug could be continued for a maximum of up to 7 days. So, as I mentioned, this was a study, a pilot study undertaken to find out if we could actually do such a study. And so our endpoints were not mortality or ICU stay. They were feasibility, which we defined as the proportion of eligible patients who are consented and randomized. So just to elaborate on this, suppose we found that we had 100 eligible patients, but we could only consent 5% of them. We'd not be able to draw valid results from that. So we said we have to be able to consent at least 30% of those patients who are eligible. And we also said that in order to do a full trial, we have to be able to recruit at least 1 patient per month from each study site. We also then, the other endpoint for this pilot study was acceptability, and that was the proportion of patients who were randomized who remained in their assigned treatment arm. So our hypothesis here was we would say to the clinician, enter this patient in the trial. If you're at all worried about them, take them out of the trial. If you want to stop antibiotics, stop antibiotics. If you want to start antibiotics, start antibiotics. But just do it based on your clinical gestalt because that's an endpoint. The clinician taking the patient out of the trial became an endpoint. And we said that would only happen 20% of the time, no more than 20% of the time. And it would happen equally in the 2 arms, the placebo arm and the intervention arm. So this is the flowchart of our study. It was run in 8 different centers in Canada. We screened 742 patients, had to exclude the vast majority of these, most commonly because they were already on antibiotics or had a new positive culture. That left us with 179 patients who were eligible. 41 of these we couldn't screen for consent for a variety of reasons. 138 of them we screened for consent. And interestingly, of those 138 patients, 80 of the patients consented to be enrolled in the trial. 58 refused, and this was equally divided by the physician saying they didn't want the patient in the trial or the family saying they didn't want the patient in the trial. Of the physician refusals, they were equally divided by physicians who said, no, look, I want to give antibiotics, or no, I really don't want my patient to be exposed to antibiotics. So we got the population we would like, with the exception that we lost a lot because they were already receiving antibiotics. These are the demographic characteristics of the patients. They were middle-aged, as most ICU studies are. They were predominantly male. They'd been in the ICU for a week and a half on average, moderately sick when they came in, a predicted mortality of about 25%, moderate degree of organ dysfunction. There was some imbalance in the number of patients who were mechanically ventilated and equally in the number of patients who had a respiratory diagnosis. And about half of those patients had had prior episodes of nosocomial infection. So one of the things we did is we asked the clinician, do you think this patient is infected? Because we wanted patients who the clinician was genuinely uncertain about. And that's who we got. You can see that most of the patients fell in this neutral area where the clinician said, you know, I really don't know if they're infected. Some said, yes, the patient's likely infected. Very few said, yes, it's very likely. Some said, no, it's unlikely that the patient's infected. So we were getting this group where there's this diagnostic uncertainty. We then asked the clinician, okay, given the clinical status right now, if this patient were not in the study, would you start them on antibiotics? And what we found was that about 15% of the time the clinician said, yes, I would start antibiotics. About 30% of the time the clinician said, no, I would not start antibiotics. And over half of the time, they said I might start antibiotics. Over half of the time, the clinician said, no, I would not start antibiotics. So clearly this was the population of patients we wanted to study. We weren't sure what was going on. We didn't feel strongly enough about it that we would start them on antibiotics. And that was really the population we wanted to target. Now, it turned out that a fair number of these patients ultimately proved to have an infection. The endpoint was the clinician's diagnosis. This was when the patient could be started on open-label antibiotics, was when the clinician made a diagnosis of infection, and that happened in over half the cases. We also, though, had a formal adjudication process where 2 clinicians reviewed the records and said, is this truly infection? And we adjudicated 40% of those patients as having an ICU-acquired infection. So what I want to show you here is the accuracy of the clinical diagnosis of infection. What we've done here is taken the clinician's prediction of whether the patient is infected and the adjudicated estimate of whether the patient is infected. This white line represents what you would see if this was happening by random chance. Anything above the white line says that clinicians are actually better than random chance in being able to make the diagnosis of infection. When it falls below the white line, it's that clinicians are slightly worse than a coin toss in being able to predict whether the patient was actually infected or whether the patient should be started on antibiotics. So this said very strongly that our capacity to make the diagnosis at the bedside is very, very poor. It's at best as good as random chance, certainly not better than that. Here are the sites of infection. The majority of them were pneumonias, ventilator-associated pneumonias, some urinary tract infections, blood, usually catheter-related infections, 2 wound infections, and 2 patients with Clostridium difficile colitis. The infecting microorganisms were the usual bacteria that we get in ICU-acquired infections, Staphylococcus aureus, most of these methicillin-sensitive, Pseudomonas, E. coli, and coagulating negative staphylococci. Now, this is kind of intriguing. We looked at the impact of being infected on 30-day mortality. And those patients who were not infected had a mortality rate of 22%. Those patients who had an indeterminate probability of infection had a mortality rate of 19%. Those patients who were ultimately adjudicated as infected had a mortality of 12.5%. That was just at the level of statistical significance. You would do better in this study if it turned out that you were infected than if you were not infected. Now, that may seem counterintuitive, but I think the explanation for that is that these patients are all sick. These patients actually have something that can be treated that's making them sick, whereas these patients aren't going to respond to that intervention. But it was an intriguing finding. Okay, so now to the endpoints. As I said, our primary endpoints were feasibility, and this was just our ability to recruit patients, and acceptability. So our consent rate was 58%. It was well above the 30% consent rate that we thought we'd have to have as a minimum to be able to draw generalizable conclusions. So that was good. Our recruitment rate was slow. We only had about 3/4 of a patient a month, and that meant that it was going to take an awful long time if we could do a full clinical trial. So that was somewhat disappointing. We then looked at the acceptability, and that, again, is the percentage of patients who are kept in the arm to which they've been randomized. In other words, can clinicians see or sense a difference that would cause them to take patients out earlier? So we had a total of 6 protocol violations, which were taking the patient out of the study before the microbiologic endpoint had been met. So that was less than the 20% that we wanted to see. It was only 15%. Of these patients, only 2 of them were ultimately adjudicated as being infected. But we were very surprised to see that all 6 of those patients that were taken out prematurely had been in the placebo arm of the study. So the p-value associated with that was p equals 0.005. So something about this population of patients seemed to be making the clinician uncomfortable to the point that he or she was taking the patient out of the study. And our hypothesis was this should have happened with equal frequency in both study arms. When we looked at superinfection rates, we did in fact see that those patients who were given active antibiotics had a higher rate of superinfection with enterococci. Not statistically significantly overall, but there certainly is more superinfections in the active treatment group. We then looked at some of the clinical outcomes, and I would remind you that this is not our primary outcome, but it was quite striking what we found. Mortality rates at 14 days favored patients who were receiving antibiotics. At 30 days, they favored patients who were receiving antibiotics. Not statistically significant. The length of stay favored patients who were receiving active antibiotics. Again, almost at the level of statistical significance. When we integrated these as ICU-free days over 90, there was in fact a statistically significant signal that favored the early administration of empiric antibiotics to those patients. And so obviously it meant that a larger study would be unethical and really not feasible to do. The other thing that maybe suggested that there was some benefit here was that the survival by randomization group, this is the Kaplan-Meier curve. You can see the patients who had active antibiotics did better. All of the patients who were doing better were those who had adjudicated infection. So the benefit was only seen in that 40% of patients in whom we'd actually made a diagnosis of infection. Just to get an idea about the time between entering the patient in the trial and establishing a microbiologic doses, it was about 41 hours on average. So the patients in the placebo arm had a delay of about a day and a half for those who were actually infected before they received their antibiotics. So we ended up with a result which was utterly unsurprising to some. Some people looked at this and said, well, this is crazy. This was unethical. Who would ever withhold antibiotics in a patient who's in septic shock? To which I would answer, these are not patients in septic shock. These are not even patients with infection. These are patients we don't know who are infection. Who would withhold antibiotics? About 75% of the clinicians who were caring for those patients. But early antibiotics did appear to be efficacious there. We've submitted this to one journal who said, listen, that was not your primary endpoint. It's a small study, and we certainly don't want to be publicizing indiscriminate use of antibiotics, and I agree with that. It's made it somewhat difficult. But they did appear to be efficacious. There is a little bit of a cost of increased risk of superinfection. Clinical diagnosis is highly unreliable. And I think what it really speaks to is that strategies to try to minimize unnecessary antimicrobial use in the ICU probably have to not target the initiation of those antibiotics, but actually target either the spectrum or the duration of therapy for patients who are receiving antibiotics. Thanks again for your attention. I'd be happy to take questions.